Welcome to the next episode of Mic'd Up with ChiroUp. Today we're going to dive into a case that many of us in musculoskeletal health will find a touch too familiar. We're going to really dive into a case study of a 50-year-old female with chronic hip pain that's been really stuck in a frustrating middle ground between really a conservative care, both from my office and also from other offices in the area. And to be 100% honest, we're just not cutting it. And pun intended, surgery is what she's trying to desperately avoid. So stick through this podcast. We're going to go through a case study of this middle-aged female patient and her journey through hip pain. I'm going to talk about the journey that her and I have had with joint mobilization, manual therapy, that just didn't quite move the needle on what she was looking for. And then how I integrated ancillary services like regenerative medicine, including PRP injections, not in my office, but in an office in the St. Louis area that does those things, and really how we were able to turn this tide. And I think this is important. It's important because, one, we've been getting feedback on how we need to include case studies in this podcast and our blogs. So that's one piece of that. However, I'd really like to explore the team-based, the evidence-driven approach that really does lead to better outcomes for our patients. And probably even more importantly, as where we fit into that collaborative effort. Where are we positioning ourselves as key players in medicine, in regenerative medicine, in conservative medicine? Where do we fit in? And then at the very end, Tim and I are going to go through a short discussion on really how the EMR system is trying to drive these support decisions and speed up this type of collaborative care in your practice. So really, whether you're a clinician looking for clinical pearls, if you're a practice owner, kind of exploring new growth through integrations, or just someone that's, fascinated by the future of conservative care, I think this podcast is for you. Like always, if you like this kind of information, please share us with your friend. We're always looking to grow and to talk to more people like yourself. So not to waste too much time, this patient of mine, and this is a true patient, we're just going to call her Sally. However, Sally is a 50-year-old female presenting to my office. She has grade 3 hip OA, and it was diagnosed on x-ray. We saw significant joint space narrowing, and we saw degenerative changes. However, really, Sally is pretty fit. No comorbid conditions, no medications. I mean, to date, she did have a corticosteroid injected in the hip, which did nothing for her. However, joint mobilization, joint manipulation, soft tissue, she's done dry needling, she's gone through courses of physical therapy, and really despite these measures, including myself, she just still has significant limitations, and she is unwilling to even consider total hip replacement. So this is someone who really presented a little bit different at the very beginning. So let me cover that just so everybody has a clear idea of what kind of shape Sally is in. And Sally really actually had some nerve radiation down into her leg, which is why she was referred to me from the orthopedist. However, what we know is that people will, in the case of hip osteoarthritis, about 47% of cases will have some referral down the distribution of the saphenous nerve. So that's why she was coming in. It wasn't a sciatic nerve issue. However, what she did have in her history was essentially a fall onto concrete. It was about 3 years earlier. She never rehabbed it. She had significant pain and limitation in range of motion. She was non-weight bearing from what I remember for about 4 weeks after the fall. Really probably a suspicious fracture. However, it was never diagnosed, never x-rayed. However, she never walked the same since. Now, when she first came in, her lower extremity functional score was around a 15, which is awful. I mean, it's severe limitation and disability. Her range of motion in her hip was less than 5 degrees in internal rotation. She was less than 35 degrees in external rotation. Groin pain, hip on the outside. The lateral hip pain was also present. Hip extension was non-existent from my initial note with her. And then she, clearly had some hip flexor hypertonicity and some irritation in the external rotators. So that's the patient we're working with. That's Sally walking into your office. We see the functional disability. We see the orthopedic tests that are positive. What did we do for her? And by we, I mean, how did Brandon fail with this patient? Well, what I did was joint manipulation. I did a lot of manual therapy to the hip flexors and external rotators, including soft tissue massage, including we did some dry needling with her. We did a lot of rehab, a lot of directional therapy exercises, which did provide her with some relief, but unfortunately never really got her past about 45 to 50 degrees of external rotation. And she was in a little bit of internal rotation, and really hip flexion never increased at all. So she walked with a limp, very forward antalgic position. And unfortunately, I just didn't get very far with her. So in the first 4 weeks, I was like, listen, we're not seeing too much improvement. While her pain was better because she wanted it to be better, I was not seeing the objective improvements. We did x-rays, and that's when we found the grade 3 osteoarthritis. And I said, you know what, let's send you back to the orthopedist and let's see what they have to say about this hip, because they thought it was a back problem. And that's when I met the first brick wall. And the first brick wall was surgery was not an option. Surgery was not going to happen for Sally. Sally said she works actually with the hospital system. She has seen too many case studies or problems that have happened with surgeries. And while she was a touch over dramatic, they were all realistic psychological fears over going through surgery. And I can buy it. It's her body. She gets to decide what she wants to do. So I've got a very good relationship with some orthopedists in the area, one who does regenerative medicine. And I thought to myself, this is a great insertion point for this kind of patient. However, I'm not a big fan of just sending patients out for care. What I prefer to be is a quarterback, saying I'm going to send you out for this care, and then I want to be involved in this care. So for the rest of this podcast, what I'd like to describe to you is, one, is how I educated my patient on what to expect, what are PRP injections, what are stem cell therapies, what it can do, what it can't do, and then at the end, kind of go through how I was a piece of that. As an evidence-based chiropractor, how can I support my patient through this ancillary therapy and help her alleviate symptoms? So let's first talk about regenerative therapy. So whenever you have moderate hip osteoarthritis, the articular surface, the cartilage is degenerating, and we know that. However, you start to have some inflammatory mediators, and you can do things like traditional therapies like corticosteroids. But you and I know that's a short-term relief. It's going to reduce inflammation, but it's really not going to repair tissue. And in fact, with repeated steroid use, can even accelerate cartilage loss. So this wasn't a good idea for her as far as the injection. In contrast, what I sold her on, and I shouldn't say sold her on, what I gave her the information for is that PRP is a natural way, and stem cells are a natural way to modify the joint, let's call it environment, and promote tissue healing and really just promote regeneration and not just mask symptoms. For, so relatively young Sally at 50 years old, her idea was to not have surgery. And this is essentially a biologic approach to slow the disease progression and improve joint function. As we are chiropractors, we can slow the progression of degenerative changes. We keep the joint moving. We get that joint full range of motion. But unfortunately, for Sally, it just wasn't enough. She was not able to regain that range of motion. And unfortunately, functionally, she was going to continually not only irritate that joint, but the tissues around her. So what PRP can do is, really multifactorial. So in my conversation with Sally, PRP is a blood product, and it's coming from her own body, and it's going to concentrate those platelets. They centrifuge them down. They really get the growth factors. Those are our TGFs, our IGFs. These are things that can actually stimulate repair processes that we can actually inject right back into the joint. And what these things do, what these platelets do, is they can reduce the inflammatory cytokines, and then that's the important part. Even a steroid can do. However, the second piece of this is the most important part, is that it can actually promote the anabolic factors. They're going to help promote cartilage regrowth. So this is something that, yes, we can decrease the pain. However, the effects of PRP, the onset of its positive effects actually are very gradual. So while a steroid injection, day 1, day 2, we're going to start to see that inflammation go away. If we're looking at a PRP injection, we're really addressing the the underlying pathology. We're improving the cartilage matrix production. We're going to reduce those catabolic enzymes. This is a way that we're really going to leverage her own body's healing components to treat the arthritis. Now, another thing that the orthopedist that I use also uses is mesenchymal cells. And while I'm not going to try to spell that online, that's why I use Grammarly. These are the stem cells. This is the things you hear about. And you can use stem cells from both your bone marrow and also adipose-derived cells, really depending on where you're going to inject. And these things are going to support tissue repair. So this doesn't, really regrow the cartilage, but what it's going to do is help enhance the cartilage repair and reduce inflammation. So your stem cells also in isolation, but also in combination, can really augment the positive effects of your PRP injections. So this is one of those things that, people think of a bone marrow transplant or it's going to be painful. It really is not that painful of a procedure to actually get these stem cells out. It's actually more painful just to put them back in. So something you might want to think about with your patients as far as what these things can do. Now, as far as PRP and we'll call them mesenchymal stem cells or MSC therapies, these are minimally invasive. So these are much less risk compared to a joint replacement, and can hopefully prevent the need for surgery, or could really postpone surgery. So something we want to think about for those types of patients who are kind of young. At 50 years old, we don't want to have multiple hip replacements. And then another key factor of these types of injections, as far as the benefits, is that they can be repeated. So not only are PRP injections can be done once, but also what we're finding is that repeat or booster injections can help maintain the benefit. So really a great conservative management tool that we can use. And some chiropractors offer that in their office, and some people we can send out to, but something that I could offer to Sally that are going to help her. Now, just like anything else, we're going to have indications and contraindications. Not everyone that has hip osteoarthritis is probably a good candidate for regenerative injections. So what are the actual indications? And we need to have something as far as structural damage. So just moderate DJD, but really once we start to get to grade 4 bone-on-bone osteoarthritis, their response rate is significantly less. Also, a good indication is your patient expectations. The patient's looking to delay or avoid surgery. These are patients that aren't expecting miracles. It's not going to happen in a day or a week. However, we're going to start to see progress, and it's going to be a slow progress. Healthy patients. This is unfortunately a pretty big inclusion criteria, is we need the patient to have overall good health. Things like diabetes or autoimmune diseases or anemia can really have a problem with this kind of therapy, because they are going to have an augmented immune system. So something we want to think about. And then really, this is not something I'm going to jump into. As a provider, this is expensive for my patients to go through. However, I always want to go through a trial of conservative care first. So regenerative therapy is indicated only after they've done physical therapy. They've done chiropractic. They've tried non-steroidals. They've had the corticosteroids. They've tried things like prolotherapy, hyaluronic acid, and they just have not gotten that long-term relief. And then this is probably my biggest inclusion criteria for my patients that I send for PRP injections, is I want them to be rehabable. Not really sure if that's a word or not, but I'm going to make it a word, because this is not hey, inject it twice and your hip pain is going to be gone forever. We really need to make sure that patient's willing to engage in the rehab, which I'm going to explain to you how we co-treat it in our office. They're willing to go through lifestyle modifications, post-injection, to help prevent this from happening again. These are all the things that I think are positive things that we can group together and decide if this patient is willing or acceptable or are able to get these kind of injections. Now, there are some contraindications, and I had to dig through a little bit of research for this one. Obviously, infection, anytime you're breaking the skin, there's always the risk for an infection, so there is that. We don't want people that are immunocompromised, so patients that have HIV, chemotherapy, people that have autoimmune diseases on things like Humira or Remicade. These are things where, their infection risk is higher, but also that immunocompromised state may alter how the PRP works. The other is blood or bone marrow disorders. Obviously, we don't want to take any kind of issues and make them worse. PRP can kind of be ineffective if you have a platelet dysfunction or low platelet counts. So we want to make sure that we have a person that we can harvest good tissue from. If a person's on any kind of anticoagulation drugs or NSAIDs, probably want to stop doing that because we are going to be impacting that. So something we want to have them discontinue right before the injection. And then any kind of history of cancer. Now, I had a really interesting presentation, not I did, but I viewed a really interesting presentation that Logan had their, Logan College Chiropractic had their homecoming not too long ago. And they had an orthopedist there who did a phenomenal job talking about PRP, which kind of sparked my interest in doing this podcast. However, the history of cancer, and this is one of those things that's kind of been on my mind. So I did dig through the research, and he provided the best research on, listen, this is not going to cause cancer. It has never been shown to cause cancer, but it is one of those concerns that whenever you're starting to pull tissue out and then inject it back into an area to speed up the growth and healing of tissue, could we be speeding up the growth of cancer? And the answer is no, but it's always a concern with us. So what does the research say? So, now that I've got this patient comfortable, I've got her excited about, using her own body to heal herself. I really needed to show her the evidence because we can really all have our opinions on should we have someone do something, but really what do the facts say? And what I've seen, and I tried to do my evidence review pretty recent. So I think my latest paper, and I'll include the research papers at the end of the podcast. However, this is really from, I think, 2022 through current, and there's been a growing level of evidence in the orthopedic literature, and it's starting to change. So I want to summarize these key findings. I want to give you the high-quality studies that I've seen, and then to really come up with an idea of what to expect for these patients. So as far as PRP, PRP in isolation, and I really tried to go through just the lower extremity and more importantly, the hip. I found one systemic review from 2024 showing reducing pain, improving function, and no adverse effects. We also see that it's not just the injection. There's another paper that says it's better than hyaluronic acid. So we're not just promoting an immune response. It's really the PRP and the stem cells that are not only getting the inflammatory response to augment, but they're also helping that tissue rebuild. It also is better than cortisone. Now, here is one little detail that you might want to talk with your patients about is that cortisone is actually pretty fast and effective in the short term. However, when it comes to cortisone, within a month to 2 months, we start to see those effects diminish, then they need another one. And what we see in the PRP group is they're still getting better and better results that is progressively improving 6 to 12 months out. So that is that's a key selling point. Also delaying surgery, as we find from the research that maybe even for the patients who do end up needing surgery, they can go longer before that surgery is needed to hopefully prevent the re-surgery that most patients obviously don't want to have. Satisfaction rates are through the roof, so this is something that is good. Also with PRP, since you're using the patient's own blood, there's virtually no risk of rejection or allergy. So we're not going to see systemic side effects like you can with some steroids, which is a concern for those patients who are diabetic. Bottom line, for patients with moderate hip OA who want to stay active, who want to avoid joint replacement, PRP is safe, it's evidence-backed, and it's at least an option worth discussing. Now, after that presentation that I went to, I was intrigued, let's just say, for stem cell therapy. So looking at these mesenchymal cells, really what we're looking at is these can help reduce pain, can improve functional improvement, and even with some of the studies I'll include on here will show MRI cartilage repair. That's pretty cool. Same thing with stem cells is we're going to get minimal adverse events. This is a very safe option because it's coming from your own body. I also included in the show notes, there's a narrative review by, I think it was Entisari, 2023, but really high quality studies that for the most part, pain, functional improvement, yada, 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 everybody's doing better. What I found interesting on these studies, though, is they're showing actual positive image changing. We are seeing regrowth, regeneration of cartilage. I mean, what better for our patients than actually not just masking symptoms, but now improving, how they're going to feel today, but also up to 1 to 2 years. That leads me into the second part of this, is how long does this stuff last? Some of the case studies and pilot studies that I went through, 1 to 2 years. This is something that not only lasts for 1 to 2 years, but you can do it again after the fact and get another, set of 1 to 2 years out of it. So really kind of something that is growing, at least in my interest, to avoid spine surgery, or in this case, hip surgery. So I hope this is something that I think that you may consider. If you don't, that's, we can all do what we want to do as far as, healthcare and being an evidence-based provider, but something that I've had an interest in, because what I don't want for my patients, like, hey, I tried everything, sorry, you have to go get surgery. Let's find something that is safe and effective for our patients to do, and ethical, where we're finding this is coming from their own body. And so I think we're seeing a change in the regulatory bodies. We're seeing a change in possibly insurance in the future, because what I saw in, before 2021 is that clinical guidelines were very cautious. No one was endorsing regenerative therapies, largely due to the newness, not the application, not to the procedures, but really when you went through, the expert panels kind of recommended against the routine use of PRP in stem cells, just because there weren't any observed harms. However, there was just insufficient high-level evidence at the time. But now, what we're starting to see is this is changing. So I think it was 2021 Royal Australian College of General Practitioners guideline really went from taking a negative stance and don't do PRP to now a neutral stance. So neither for nor against, but also that shows a big stance saying, hey, we're coming out of dissuading patients from going through PRP to now saying, hey, this may have a positive impact. So while official guidelines are always going to lag behind the current evidence-based practice, we have to utilize these as justification for providing these as an option or not. And one other thing that I do want to cover is just what is about to happen to the patient. Because before going into practice, I actually sat in on a pain management or pain interventionalist procedure day, and I got to see epidural steroid injections. I got to see discograms. I got to see radiofrequency ablation. Holy cow. These are things that I'm going to treat as a last option. They weren't very enjoyable to even watch, more or less go through. So what happens with PRP injections? And this is something that I was able to view, and it's a lot easier than I was expecting, to be honest with you. I mean, the blood draw was 5 minutes. They're going to take a couple tablespoons of blood from your arm, just like a normal blood test. Nothing looks different. They're going to spin your blood down. It took about 15 minutes to do this in a centrifuge, and then they're going to be able to extract the PRP. I think the technician called it the good stuff from this tube, and then they have to prepare the injection. They're going to numb everything up, and then the provider that I went it was about a 20-minute procedure where they actually use ultrasound to guide the needle into that area. They don't use lidocaine. There are some providers that I know that do lidocaine first and then inject the area. The place that I went did not. So you will feel, obviously a little pressure and discomfort, but it's usually quick. And the patient can go home. They're going home that day, and they're going to start to feel better within a few days to weeks. But really, the full effects are not noted until 6 to 12 weeks. Whereas if you look at a cortisone patient, they're going to feel better 24 to 48 hours. The stem cell option did take a little bit longer. They did do lidocaine for this injection to numb the area, and it was done from the pelvic bone. Surprisingly, the patient did not squirm very much, so something that did not appear to be that uncomfortable. The last piece of PRP that I want to cover is timeline of improvement, because this is something that we want to have good expectations with our patients. So with PRP, You're going to start to notice improvement with 2 to 6 weeks after the injection, but significant improvements are often going to occur at that 3-month mark. Really the literature is between 6 and 12 weeks, and because that's how long it takes tissue to start to lay down a new cartilage matrix to reduce synovial inflammation. With the mesenchymal cells, this is also going to follow very similar, but it's going to take a little bit longer, maybe 4 to 6 weeks to start to see that improvement. And then a lot of times with the clinics or the businesses that are doing these, they do a booster shot, and that's going to be 3 to 6 months after the first one, and only if the response is good. So letting your patient know what to expect. Most patients within the first injection will be 30 to 50% better, which is pretty exciting. They're going to have improved function, improved mobility. Everyday activities are moving pretty good. And really in that 6 to 12 months is when they're going to start to see the full effect of that. Now, I gave you the little teaser, and I want to make sure that I cover this because for Sally, I was still a part of their care. So now, what can I do as an evidence-based chiropractor to help Sally through her procedure and also to get her back to where she was? Here's what I did, and it's rooted in evidence, but it also is just the protocol that we came out with that makes the most sense for my clinic, Premier Rehab, because I know that I wanted to optimize outcomes, to protect that joint, and to make sure that I was supporting not only her, but also the work of the orthopedist that I sent to. So here's kind of the flow that we went through. And really in the first 3 to 5 days, so the first week after injection, I kind of told her that relative rest, let's just do whatever you need to do for pain management. We want to make sure that we avoid a weight-bearing stress on the hip. We want to make sure that you avoid long walks or running or carrying heavy objects. You can do some open kinetic chain, typical range of motions like your hip circles or pendulum movements. All these things are found in ChiroUp if you want to take a look at those. But I really actually avoided any kind of direct manipulation to the hip. I was still going about my business with the spine and other areas. I don't use a lot of ice. It's not that I don't think ice is good. If you have any questions on ice versus heat, Dr. Berlesman wrote a great blog on that. Check that out. But really, heat is probably the best option. In my opinion, the hip joint is inches deep. You're not really going to affect anything, at least for this kind of patient. Also, I did advise her against NSAIDs. This is something that's going to augment the inflammatory process. However, so are my biologic agents. So I want to let them work and not try to blunt the external pain with NSAIDs. Now, when I hit weeks 2 through 4, I actually saw her twice a week for 2 weeks, and I did some gentle therapeutic exercises. This is when you can go through full range of motion, low load, low impact exercises. I did some directional therapy exercises to get her into extension, and I focused on external rotation. I did no resistance, and I did no overpressure, just some gentle passive stretching. I also did some soft tissue around the hip flexors, the hip external rotators, the hamstrings, just to reduce any compensatory tightness and help improve that range of motion from a soft tissue standpoint. Once again, I was not manipulating the patient. It's not that I don't think I could. It's that I was really kind of just interested in this flow. What if I gave her a month of just letting the body do what it does? So we did some joint mobilization of the SI joint, the lower back, but I kind of stayed away from the actual glenohumeral joint. Now, once I got to the end stage, which for me was between that 4 and 8 week mark, this is where, if you look at the research, the healing has progressed to a point that I can gradually increase the load that I perform on her and really that she can perform on herself. So what I did is create a structured exercise program, and really, if you want to look at it, in ChiroUp, it's the hip abductor program. Hip abductor weakness protocol that we have in there to help promote some hip strength. So how am I going to emphasize, gluteal muscle groups, the medius, the maximus, the minimus, some balance stuff, some clamshells, some bridges. Those are kind of things that we can start to do. Could she have done more at that time? Yes, 100% yes. And she was begging me to do more. However, With this kind of thing, I want to encourage low load things like cycling, like swimming, like using an elliptical, to keep that cardiovascular fitness up, to improve joint nutrition through, that synovial fluid circulation, but really trying to avoid impact. The last piece is balance and proprioception. I love the single leg stance, and I love Vele's exercise, VELE apostrophe S, which those are probably my two favorite exercises in ChiroUp. I shouldn't say ChiroUp, in the entire library of things that you can provide to someone to improve balance. Joint mobilization, obviously the same thing I talked about before. And really, we had great results. So for 50-year-old Sally, with moderate hip osteoarthritis, this was about 6 months ago to maybe a year ago that I had her. She's still doing great. Her hip external rotation from my last visit is actually at about 65 degrees, so it's not bad. She's able to walk with still a touch of a limp, however, much better. She's not doing surgery. She is doing very good. She's playing pickleball. That really, she has had some meaningful pain relief, some improved mobility, better quality of life. I will say it's probably not a complete cure. Here, if we did some imaging, you're still going to see some grade 3 osteoarthritis, but the structured rehab program and letting that tissue heal and then going back in to go in and improve that hip strength has been clinically meaningful to her. So I hope this has been helpful as far as a case study on what I did with someone with hip osteoarthritis. A typical person with hip osteoarthritis, I'm just going to follow the protocol that we have in ChiroUp. It's simple, it's easy, it's standardized, it works, it's research-based. However, for people not getting out of pain, we just don't give up on them. What else can we do to meet their goals? And in this patient, who does, to be honest, has the financial means to try other things as compared to not, because most of your PRP injections, you're going to be shelling out $1,000 to $1,500 for that first visit, and then most of your boosters are between $700 and $900, and it depends on your area and which provider you're seeing. And this is a cash service, so not something that everybody can afford. However, something to at least consider. Now, at the end of this, I want to bring in Tim. Tim has some insights that I want to bring up. We're just north of 100 clinics in our EMR, and boy, we have learned a lot. So I want to cover the three top things that we've learned really just in the last 6 weeks on the EMR, and really some surprising things that I think are going to help you maybe revolutionize your practice. All right, I finally got Tim in the room for the last part of the podcast. We're going to go over three main things that we've learned about the EMR with the first 100. The first 100 clinics are on board using the software, and I have never been more surprised by the way people run a clinic. And not in a bad way, but every chiropractor that we touch, every chiropractor that's in our network uses the system in different ways. So I want to talk about those and how we've adapted the software to meet those needs. Tim, welcome to the end of the podcast. He was sleeping during the first half. I had to wake him up from his nap, but thanks for joining us.
I don't know if that's age or what it could be. I love what you've done with the room, though. It's beautiful. I love the disco ball, the lighting. It's nice, flashing.
All right, so number one. This is the number one thing that we heard from the very beginning. One of the biggest pain points in chiropractic software is billing, specifically posting ERAs. And we've heard from users, even before the software was up, how can you make this fast? How can you make this accurate? Can you kind of walk us through our flow in this? And with an understanding that we incorporated a clearinghouse into the software. So people never actually leave the EMR when they're doing any of these pieces of functionality.
Yeah, a couple clearinghouses. And what's nice is with those integrations, the amounts, the appropriate adjustments, those are automatically populating when the ERAs come in. So you bring money directly back into each patient invoice with a button. I think really the big thing is the theme throughout the software, that our software wasn't built with a component that then had add-ons, that we didn't start with a notes program that then had to add billing somehow, or a billing program that had to add notes. We started with the thought of how do we make this all seamless? How do we make it work together so that you don't have to leave the system, everything talks to each other, and at the end of the day, your notes are done, the bills are sent out, and the click of a button, the money comes back in.
Another thing, not to rain on your answer here, is that I didn't realize so many clinics use billing companies. And so we have a natural flow in our system that if you have someone in your office that's that's going through these claims, it goes through, the pending files and unsubmitted, and goes to accepted, and hopefully no denials or rejected, of course. However, one other thing that we did was make it very simple to communicate with a billing company, with the ability to flag post, to actually put notes on each claim, because a lot of the newer clinics now are reducing staff and using these billing companies. Now, if you don't have one of those, one of the other cool parts that we designed is essentially a billing rules engine. And now that we can automatically change CPT codes based on your insurance company rules, we can add modifiers to Medicare claims. There's just a bunch of intuitive features that are going to help you collect really what's owed to you. And the simple goal is, of course, to avoid denials, reduce time for you and your staff, and to make sure that you keep your practice running. Now, the big piece of the EHR at the beginning were these surveys and chief complaint surveys, and every ChiroUp member has access to those. However, one neat aspect of the SOAP note is the assessment section. I can tell you that the worst part of my day was actually writing down all the diagnoses at the end of the day on a piece of paper and giving it to my billing person. But now what we've done is we've made it in less than 10 seconds the ability for you as a provider to put in the assessment or the diagnoses. And how does that actually speed up your documentation and improve your accuracy in your note, Tim?
Yeah, I think that's one of the cruxes of the system that really makes it stand out, that I don't think it can be rivaled. And the reason for that, the reason I can make that bold of a statement, is we really flipped the way a SOAP note is done. That typically you did the subjective and then the objective assessment plan, but in reality that's not how it was done. That providers would gather subjective input, and then they would touch the patient to do an exam, to do the treatment, and then they would go to their note. Well, by the time you go to your note, you know the assessment. If you know the assessment, you also probably know what tests you did and what treatments you did, or at least what the best practices are. So we allow you to put in the assessment initially. We collect the subjective for you with the chief complaint survey. Comes in with a detailed OPPQRST. Even on the follow-up surveys, there's interim surveys, re-exam surveys. Most of the subjective information is in the note before you ever see the patient. You put the assessment in on the first visit, and at that point it says, did you do these tests? Yes, I did. Not this, but add this one. And did you do these treatments? Yes, add this one and modify this one. So my average initial visit note is going to be about 30 seconds. If I have a really long one, it might take a minute. My average follow-up note is going to be somewhere between 5 and 20 seconds. That it's just lightning fast. And I think that's what really matters most, is that at the end of the day, we as providers, if we save 20 seconds per patient, that turns into tens of thousands of dollars of revenue at the end of the day. We're looking at the end of the year. We're looking at what can we do to make each note easier, more accurate, and give you a little bit of time back.
Yeah, so if your billing is better, if your notes are better, really we're trying to give providers back time in their day. To focus on really what matters is more the patient care aspect, as far as the outgoing stuff that we can do, and also the incoming things that we can do when there is a new diagnosis you haven't heard of. Provide those strategies within the EHR to allow you to learn as you're taking a note, or usually after you're done with the day. However, what aspects of this system are specifically designed to support time savings for clinicians?
Yeah, every aspect. That taking the note is quicker, gathering the subjective input is quicker, making sure everything talks together to avoid redundancy of data is quicker. And that's the goal, is to give you more time, but also to make you a better provider. That one of the things that we've really sought is to say, how do we each elevate, including me and you, how do we elevate our practices? How do we make them just a little better? So making sure all of those assets, our tutorial videos for orthopedic tests, for treatment techniques, are hyperlinked. So now you're using an EHR that's, number one, enjoyable to use, and number two, can actually make you a better provider when you're using it. And then constantly growing, I think, is the other thing that we are continually hearing from subscribers and their staff. We have 100 or 150 clinics on board at this point, probably more by the time the podcast is out. And that means there's a lot of doctors in those clinics, maybe a couple of doctors per clinic, and a lot of staff members. So we have, several hundred people who are telling us, here's how you can make this even better. And that's where we listen. What can we do to make everybody's life easier? One of the things that ChiroUp believes that we are is not a company, but we're a mission, and that mission means that we have people, and that group of people is going to help advance each other, help advance our profession, and that's where we're headed in the long run. What can we do to advance our profession, make us that undeniable best choice for patients and payers?
Yeah, I definitely agree with that. One of the biggest, the most difficult things was developing functionality and realizing that not everyone runs the same clinic. So our biggest goal in this first year is to genuinely listen, provide a avenue, a portal for you into ChiroUp, and not only provide information but also be a part of the response. So when we send stuff to our coding team, the people that request that information actually get feedback on, hey, here's what it looks like before we roll it out. Is this meeting your goal? And really, our community is going to guide our progress and really is going to make sure that our new updates improve not only your practice, but the rest of the providers will be using it in the years to come. So thank you for listening to the podcast. Tim, thanks for waking up from your nap. I really appreciate that in the middle of the day. I think that these episodes really have become a lot more fun because not only can we go into the clinical information, but we can start to talk about the things that are affecting our company. As always, if you've enjoyed this episode, please share with a friend or a colleague that you think will be inspired by this information. This podcast is all about pushing our profession forward, and if you can help spread that message by hitting the follow button, we would really appreciate it.
Hey, thanks for listening. To access more information, visit ChiroUp.com. You can sign up for a 14-day trial. Use referral code PODCAST15 for a special discount after your trial. Offer valid on new subscriptions only.